our listeners probably don't realize that for every pound you are over your expected weight, you're putting about 4 to 6 pounds of pressure on your knees, right?
Yeah, functionally, just flat walking puts up to 3 times body weight on your knee. Upstairs, 4 times body weight. Downstairs and downhill, 6 times body weight. So every pound is almost exponential on the knee as far as the forces.
And so the most common thing you're seeing is changes in the cartilage and then promoting degenerative arthritis, right?
Yeah, it's the most common thing we're seeing. And I think it goes back to the point you were making about arthroscopy. I think it's the chicken or the egg. Is it the arthritis causing the meniscal issues or vice versa? And that's where I think we have to be very careful about recommending arthroscopic surgery for some of these patients.
Hello, everyone, and welcome to Finding Your Wellness, a podcast sponsored by the Columbia Association. I am Dr. Harry Oken, a community physician for over 35 years and the medical director for the Columbia Association, and I am proud to be working with Columbia Association for over a decade to help and assist in their mission to improve the health and wellness of our community. I'm happy to introduce my friend and colleague, Dr. Joseph Layug, who's been with us before. I think it's so important to work with doctors that not only talk the talk, but walk the walk. And that is certainly true of my good friend, Joe. He is an avid skier, a triathlete. He still competes in triathlons and does very well in his age group. He keeps himself very healthy. Dr. Layug is a native of Baltimore, and after getting his MD degree and then his orthopedic residency at Georgetown, he began to practice in Howard County in 1995. He was also chairman of orthopedic surgery at Laurel Regional Hospital from 2003 to 2016. And he's been a member of the Columbia Association's Medical Advisory Board since its inception. He has a special interest in orthopedic care of the endurance athlete and sports medicine. So today, we're going to talk about a very common problem, the painful knee. About 25% of people over the age of 50 experience knee pain, most often from degenerative overuse knee disease. And in the United States, we spend more than $3 billion each year on just arthroscopic knee surgery that unfortunately has been found to be less effective than people had once thought. 6% of people presenting to the adult primary care clinics report symptomatic knee pain. The knee joint consists of connection between four bones, the femur, the tibia, the fibula, and the patella, the kneecap. And there's four compartments to each knee, and these compartments can experience strain and injury and disease. So today we're going to talk about common causes of knee pain and how to fix it, how to remedy it. Welcome, Joe. Thanks for being here.
Yeah, thanks for having me, Harry.
This must be one of the most common things that you see in the office.
Absolutely. It's the majority of my practice.
And what's the most common cause of knee pain that you're dealing with?
Well, it depends on what age population I'm seeing, right? So, younger patients, it's going to be overuse or acute injuries. The more mature population, it's going to be overuse or some early arthritic conditions.
And so the overuse phenomena is very common, and oftentimes on top of the overuse is excessive weight.
No, there's no doubt about that.
I think that the weight problem is significant, and I think our listeners probably don't realize that for every pound you are over your expected weight, you're putting about 4 to 6 pounds of pressure on your knees, right?
Yeah, functionally, just flat walking puts up to 3 times body weight on your knee. Upstairs, 4 times body weight. Downstairs and downhill, 6 times body weight. So, every pound is almost exponential on the knee as far as the forces.
And so the most common thing you're seeing is changes in the cartilage and then promoting degenerative arthritis, right?
Yeah, it's the most common thing we're seeing. And I think it goes back to the point you were making about arthroscopy. I think, it's the chicken or the egg. Is it the arthritis causing the meniscal issues or vice versa? And that's where I think we have to be very careful about recommending arthroscopic surgery for some of these patients.
Now, in Howard County, there always is this other piece, particularly from about April to maybe October, and that's Lyme disease. And I'm sure you see a lot of Lyme disease.
Yeah, sometimes that's, sometimes these patients with Lyme disease are presenting symptoms as orthopedic. So I've seen one rash over the years, right? So what I'm typically seeing is somebody with typically a swollen knee,
Right.
for sure.
So to put that, actually move that off to, I think it's really important for people to recognize that's a possibility, but that history is quite different.
Oh, yeah, very different. Patients come in, no injury, no change in their activities, a swollen joint, which really, they don't really complain about a lot of pain in the joint. They complain about a limitation in the range of motion. And
Right.
when they push the range of motion, then they'll have some pain. But a lot of them functionally just with walking and simple things aren't complaining of pain.
And then you're going to make a diagnosis based on the exam plus usually drawing some fluid, right?
Yeah, so typically if I have a high index of suspicion, so there's been no change in their activities and I have a suspicion about Lyme's disease, I'll typically do an aspiration where you put a needle in the joint. And if it's a clear yellow straw-colored fluid, it's probably degenerative. With Lyme's disease, it's very obvious. It's just a little cloudy, a little murkier than we would expect to see. And in those cases, I'll send them off for some screening blood work.
Right. But you can also use the joint fluid and oftentimes identify the problem.
Yeah, so it's interesting. It's as Ripley's literature says, is that that's not always that accurate. I think there's been a number of cases where I had a high index of suspicion was Lyme's disease. Their blood work was normal, and the only way we were able to discover it was to do the studies off the synovial fluid.
Right. Right. And for our listeners, that situation is pretty straightforward once you make the diagnosis. And then typically what we're seeing in our office is usually acute Lyme disease characterized by rash, sometimes fever and blood abnormalities. But by the time it's caused acute a joint change or joint swelling, it's a little bit later stage and they may not remember ever being bit by a tick, an infected tick. And those patients do very well once we get them on oral antibiotics, typically for a full month.
Yeah,
Yeah.
I've had a number of cases where I just went ahead and started them on the
Right.
antibiotic. And then by the time we got the results of the synovial fluid that we drew off or the blood work, they're getting better already. So
But that's sort of a special case. We always have to keep our ears up, to find these folks because we don't want to miss that. But the more common things are ligamental injuries, meniscal injuries, bursitis, strains, and arthritis, right?
correct.
Yeah. So typically somebody comes in with knee pain, you do the exam.
Yeah, well, our history and physical is still a powerful tool, right?
Right.
So, I think our differential gets narrowed down, whether it's an acute injury, whether it's a change in their activity or overuse, or whether they haven't really done anything different at all. So I really, rely on coning down my differential based on the presentation acuity of their symptoms, whether they have mechanical symptoms, catching, locking, giving way, swelling, whether they've responded to anti-inflammatory medications or relative rest. So those are all my initial questions, which really, in most cases, based on age and their physical exam, will help cone down the diagnosis.
And the exam and the history really point you in the right direction. So not everybody needs to be packed right off for x-rays or an MRI, right?
No, that's absolutely true. I mean, I probably ignore more MRI findings in patients that show up with an MRI and tell them we still have to rely on your symptoms or your exam, or we're going to end up treating things that aren't necessarily causing problems. And I think, again, that dovetails into your earlier comment about knee arthroscopy for meniscal tears.
Yeah. So your typical person who actually needs knee arthroscopy has very specific findings, right? On exam or maybe on MRI that you can repair. In the
Yeah,
old days, I think before MRI was so available, people were using arthroscopy diagnostically.
right. That's correct. Yeah, that was our diagnostic test of choice. And of course, in those particular scenarios, right, patients have had from the time of their presentation to the time they needed or were considering an arthroscopy, there were a number of patients that got better in 6 to 8 weeks. So now we're capturing these patients because they're getting a study earlier that might have gotten better had they just given it more
Yeah.
time.
Yeah.
And so I do have to say, now minus Medicare, all the insurances require 6 weeks of conservative measures. So it is quite interesting now that I can't order an MRI on some of these patients. They come back at 6 weeks when I have to do a follow-up so I can order their MRI, and they're asking me, why are we getting an MRI if I'm feeling better?
Right.
And so I think it's a powerful tool in our toolbox, but one that we should be patient in using.
Yeah. Yeah. Because the vast majority of people unless there's something very specific on your history or examination, they're going to get better just with conservative care, non-steroidals, rest, maybe a compressive brace, etc.
Yeah, and I think that's obviously if it's a younger patient and they have no degenerative changes and they only have a tear and they're having mechanical symptoms, they're the easiest patients. I think the challenging patients are, because there is still a role for patients over the age of 40 or 50 to get a knee arthroscopy with a meniscal tear, but I think they need to have very specific symptoms of mechanical symptoms, catching, locking, giving way. And those are the patients that are going to benefit. So while the studies show that perhaps knee arthroscopy versus conservative measures are just as effective, there's outliers. And I think the more time you give patients and the more symptomatic they are and the more treatment you provide that doesn't work, I think then you sort of narrow down the patients that are going to respond well to a knee arthroscopy for meniscal pathology.
Now, our average patient that comes to see you, if they don't have a meniscal issue, they probably have arthritis, right? And many of the people that have arthritis, the core therapy is probably reduce the load that they're putting on their joints.
Reduce the load, stay active, right? I mean, most
Right.
people are looking for an excuse to not do things. And really, to your point, I often tell patients, you are not going to make this problem worse by being active, but we're going to get a lot of information and maybe benefit from you becoming more active and doing more.
Right. And then reducing the load is the great challenge because, 2 out of 3 adults in this country are either overweight or obese. And that's really the big, unless you've had an injury, that's the big issue. Who's going to get a shot with corticosteroid? Who's your patient for that?
My patient that has modified their activities, they've tried anti-inflammatories, provided there's no contraindications to doing so. My typical patient, I used to say 50, but it's gotten younger down to 40 because I think of the weight issue. And I often preface the conversation with, I'm doing an injection for diagnostic/therapeutic purposes, right? So if I do an injection and all their pain goes away for months and months and months, I tell patients, if you have a tear, the meniscus is not unstable and I'm not going to operate on it. I'm not going to look for one. If I inject someone's knee and they tell me that only worked for a couple of weeks or a month and all my symptoms come back, I tell them, well, that's the patient with, if their x-rays are normal, if they have a tear and or have mechanical symptoms, that's the person I'm going to offer an arthroscopy to.
Right. Now, there are those patients who you might have had some imaging done, maybe just a plain film, who have mild to moderate arthritis, and they often will benefit from a steroid injection, correct?
Yes, and I think it's interesting because, again, the literature is all over the place about it. And my discussion with my patients are, well, what are our options here as far as treatment goes, right? One is to do nothing. One is to put patients on an anti-inflammatory for prolonged periods of time. And the other is an injection. And I feel when we look at that risk-benefit ratio, what's really the safest thing to do? And I think, again, speaking just about the knee, using the injections not excessively is a reasonable way to manage things versus having somebody take an anti-inflammatory long-term with all the potential side effects.
And I found, and you found, injection therapy with corticosteroids is done under the right way for the right indications, very safe and reasonable to do as needed a couple times a year going forward, right? Particularly for even your patients in their 60s and 70s.
Oh, absolutely. I think as patients get more mature and they start accumulating other medical issues and they're on other medications, the last thing I typically want to do is add another medication.
Right.
And oftentimes you're telling me not to because of their blood pressure or other issues.
Right. So in those patients with the typical problem, which is degenerative joint disease, and they have loss of cartilage and maybe changes that you can easily see on the x-ray, maybe, osteophytes and et cetera, bone on bone, your next move is?
Well, I think once patients have failed conservative measures, I tell patients my criteria for your knee replacement is that your physical exam supports it, that your x-rays support it, and your brain's ready to go through with the process of a knee replacement. With the last part being the most important part, is being convinced that they need to go to the next step and they're willing to go through the recovery that's required with a knee replacement.
And before we talk about that, but the intermediate step might be some visco supplementation with the lubricant, right?
So I'll tell you, I use it all the time. Our academy just put a statement out saying that we should not be recommending this because the studies aren't showing it's any better than placebo. But I still, until insurances tell me I can't, will use that. Again, provided they're not having mechanical symptoms. If they're really having mechanical symptoms, I haven't found it to be all that effective. But I think it's something I'm offering to patients, perhaps less so over time, because I think we're going to have a harder time getting it okayed.
I wasn't aware of that, the new Academy's recommendation that they feel like it's no better than placebo, because we've both certainly seen people respond.
Well, and I think 15-20% of patients, respond to placebo. But, as I said, I think it's just another, I probably use it more to prove to patients that they need to have a knee replacement than it really helps them in the long term. I think it's like anything else. The less arthritis you have, the more effective it's going to be. So I do find it to be quite helpful for patellofemoral disease. So if I have somebody with isolated patellofemoral disease, I think they do quite well, because I think if you can give them a period where they're having less pain, they do really well with physical therapy, right? And so I think it's really, I told me, if I'm getting you over the hump so you can really do the physical therapy. So I really do, I think there's good indications for it. It's just, when patients are really moderate to severe, I'm not really finding it works any better than the cortisone.
And I'm glad you brought up about the physical therapy piece, because I do think that, patients who work with a physical therapist for their knees are able to get some balance to their muscles and articulation, particularly the patella, the kneecap on that femoral groove, and that's really helpful. So just finally, to talk a little bit more about knee replacements, and I know that you do a lot of knee replacements, and the criteria are generally intractable pain, being miserable, bone on bone, no other option other than you can't do what you like to do, right?
Well, I think you hit on you can't do what you like to do, I think is really something that as orthopedic surgeons, we haven't done a very good job in talking to patients about. And part of that is, when I finished my residency 30 years ago, the average age of a knee replacement patient was 72, and now it's 60.
Wow.
When we look at patient satisfaction rate 30 years ago, patient satisfaction with a knee replacement was 95%, and now it's 80%. So it's actually gone down. And that makes sense because we're putting them in younger and younger patients. So it's not uncommon for me to get a second opinion in a 55-year-old gentleman that's had a knee replacement, says, well, something's wrong with it. What's wrong with it? It hurts when I play basketball. It hurts when I kneel. It hurts when I squat. So I don't think as orthopedic surgeons, we need to be better about understanding, what do you want to do? What is your goal with this knee replacement? Because if you don't ask, they're not going to necessarily tell you. And I think that's where we get caught. So I think reasonable activities are low impact activities. So doubles tennis, downhill skiing, walking, bicycling, swimming. So I think as long as they have realistic expectations and goals with their knee replacement, it's a good operation.
And yeah, and it's done all the time. It's now done as an outpatient. If that's your single problem and you're otherwise healthy, you're going to make a pretty quick recovery, right?
We've made the process simpler, but I still tell patients it's a 9-month to 12-month recovery.
Right.
Not for them to get rid of their pain, but for them to get rid of the swelling and for them to get their muscle strength and endurance back.
Right. But they're back to doing their activities of daily living rather quickly. As a matter of fact, the day of surgery, they're up and moving, right?
They're up, moving, weight bearing, bending. So I tell patients, 6 weeks dominantly to return to driving, although some patients are driving sooner. But, I tell them the hassle period, 6 weeks, plan on at least 3 months of organized physical therapy.
How often are you doing both knees together?
We're doing that less and less because we've moved it to an outpatient arena. And so we're typically staging it. The other thing that we never have to do anymore are blood transfusions. And that's due to the fact we're using medications to limit bleeding during the surgery. And so I think over time, we're going to get more comfortable doing that as an outpatient. But I think now that we've moved it more to an outpatient arena, less people are having both done at the same time.
And the replacement parts are very durable now, right?
Yeah, well, the metals have remained the same. The polyethylene, which is the plastic liner, continues to improve over time. as you know, with everything we change, we need 20, 30-year results to make sure what we're putting out there is truly better than what we've been using.
Right.
In many cases, we think we're smarter about it. Sometimes 10 years down the line, we figure out not so much. But no, the polyethylene, we've all gone back to that with the knees, and it is very durable.
Right.
To your point, the weight reduction is an important part of that, right? We put the same size tires on almost every car.
Right.
And so that's important for patients to understand.
That's a good analogy. Well, last thing I want to ask you or have you comment about, which is a very common problem that I get asked a lot about, and we don't do much about it, is the popliteal or Baker's cyst. You see that a lot, right?
See it all the time.
And can you explain to our viewers about that problem?
So a Baker cyst is a collection of fluid behind the knee that is rarely, if ever, an isolated problem. It is usually related to a problem within the knee itself, with the two most common things being a meniscus tear and arthritis in the knee. So my analogy, I hate going back to the car, but my analogy is your knee's a radiator. Your popliteal cyst is the overflow reservoir for your radiator. It should never be there unless the radiator overheats.
Right.
So I tell patients, really, the treatment of a Baker cyst is treating the pathology within the knee itself.
Right. But people may walk around with a Baker cyst for a lifetime and it'll never bother them, correct?
No, correct, because they get bigger and smaller depending on how irritated the knee is.
Got it. Great, great. Hey, this has been a great discussion. Thanks for being a guest again. I really appreciate it. This is such a common problem that you're seeing, I'm seeing, and it's good to put that information out there to our listeners. And thanks to our audience for listening, and thank you to the Columbia Association for sponsoring Finding Your Wellness. You can listen to our podcast from Finding Your Wellness by typing into your browser dragondigitalradio.podbean.com. This is Harry Oken for Finding Your Wellness.